of debate and controversies. Debate between the practitioners, especially infectious diseases and critical care. And then you can imagine for somebody who's doing both, it's really problematic. I cannot be on which side of the two parties. But then we have to refer to the literature. And the problem with the literature is that there are a lot of confounders in relation to de-escalation studies. I know that Prof. Huda has prepared some surprises for you today. So stay tuned and then you'll see more about that. But these confounders brings a lot of biases. Here are some of the challenges related to studying de-escalation or taking or extracting conclusions from de-escalation studies. Because the definitions of de-escalation are not fixed. Sometimes de-escalation in different studies referred to as decrease in number of antimicrobials, sometimes narrower spectrum, sometimes shortening of the duration, sometimes cessation of the treatment is defined in some studies as such. So having one definition is really problematic, and you cannot compare apples and oranges in that way. Even the spectrum, changing to another antibiotic in the same class may be thought de-escalation, like meropenem to ertapenem, or fourth generation cephalosporin to an earlier one. Some people define that as de-escalation. The other thing, since it is the same class, that is not de-escalation. Or changing to another antibiotic in another class, say meropenem to another class like tigacycline, or cefepime to levofloxacin. Here's a consensual ranking of beta-lactams according to both their spectrum and their resistance promoting potential. So they rank 1, 2, 3, 4, 5, and 6 depending on the spectrum. But this is what these researchers and experts have thought would be possibly the best way we should rank beta-lactams. You could very much possibly, based on your practice, think otherwise. If you take the example of piperacillin-tazobactam, which is rank 4, and compare it to rank 5, which is ertapenem. In my assessment, my personal assessment, I think piptazo covers more than what ertapenem would. Ertapenem may cover ESBL, but it doesn't cover enterococcus. It may cover certain antimicrobials that ertapenem may not cover it so well. So this is the ranking based on one thought of idea. If you take the other ideas, you take it from there. I think tigacycline may cover broader aspects of bacteria compared to meropenem maybe. But meropenem is still considered the ultimate. So even defining what is the broad is also an issue, and that brings a lot of debate. Also, these studies have different designs. Some are retrospective, some are prospective, and some are randomized. Unfortunately, the RCTs among them are very scanty and few. These different studies looked at different outcomes. In order to say that we have attained what the good outcome of de-escalation, we might be looking at resistance, mortality, cost, recurrence of disease, relapse, and emergence of MDRs, superinfection, C. diff, you name it. So these are different outcomes that we still